Hey, everybody. It's Karen Anderson here with our week in review. Oh my goodness, I feel like I've been gone forever. It's not like me to not be here for every single thing aortic disease awareness month related, or quite frankly, for just everything. I'm not used to not being here. So much has been going on in my world, which we will get to at some point. But for right now, why don't you go ahead and click subscribe, click that bell so you're notified all the time, every time that we go live. This way you won't miss anything because we have so many things, especially this month. We have a lot. We have 2 live events happening today, one immediately following me with Dr. Ben Udelman. So you definitely don't want to miss that cardiothoracic surgeon, very popular on our show. So that's going to be a hoot. Yeah, so there's a lot of stuff going on, a lot of interesting things that have been rolled out so far um, this month. So many different things we're talking about. But since this is last week, we're talking about and not this week, which God, next week's week in review is going to be interesting too. There's a lot of things happening live time this week that if you can check out our website and check out our Facebook or LinkedIn, you're going to see all these announcements of some very exciting things happening. But let's get started with Monday, and we're going to talk about them as we go on. Although I'm on limited time because I have this live event right after here. So let's just get cracking. All right. Okay, so last Monday, the first week of September, what we talked about was what is the aorta, right? We went over that. Very important medical information. We learned about the different zones and the areas of the aorta. Then we talked about thoracic aortic aneurysm. So that would be in the chest area. And then we talked about abdominal aortic aneurysms, right? And then we went into some of our community resources. We talked about why aortic hope and Survivor Series. We mentioned that. I think we also talked about collaboration that we have going on with a couple other patient-centered organizations. And I think we wrapped up the week with reading resources. So that was last week. So this week, what we want to bring you up to date on from last week is something that Adam was talking about just prior to us coming into this month. And that is a couple of the different types of clinicians that you might encounter or want to have on your team when you're facing aortic disease. And so they're right here on this graphic. We talk about briefly thoracic surgeon, which does all chest surgeries. So it's in the thoracic area. So that would include your heart, your lungs, your aorta, et cetera. You might also need a vascular surgeon. Now they treat arteries and veins. And that's going to definitely be anything from that thoracic aorta down for sure. Cardiologist is managing your heart related conditions. They're also great when it comes to managing your medications. So you want a good cardiologist that's knowledgeable when it comes to aortic disease. Hypertension specialist. Now that's going to be somebody totally different. And not a lot of you have heard of a hypertension specialist, but they focus on high blood pressure. That is their world. I mean, it's like a scientist, the way that they are able to take the screenshots of your measurements of your blood pressure and figure out what medications will work times a day and everything. So hypertension specialist you might need on your team. Interventional cardiologist, another someone you might want on your team. They deal with minimally invasive heart procedures. That would be endovascular type procedures. You might also need an electrophysiologist, especially if you end up in AFib or some other rhythm type issues, because they treat all the heart rhythm disorders. Okay. So we're going to specifically focus our attention on cardiothoracic and vascular surgeons. And while the two of them tend to work together when it comes to fixing aneurysms or dissections in the aorta, their expertise and their training and their common surgeries, they tend to be very unique. So who's going to treat aortic disease? Excuse me if I do cough. I am still kind of in the last minutes of having had COVID. All right. So when it comes to aortic disease, many people tend to wonder, like, which surgeon do we really need to have? Who's going to cover what? And so a thoracic surgeon, or should it be a vascular surgeon? And this is an interesting question, right? So while we talked about how they're both highly trained and they often collaborate, they still focus on different things. So your thoracic surgeons specialize in the chest or thorax, and that would include your heart, your lungs, your thoracic aorta. They also do some work on your trachea, like that whole area. It's everything. Get your lungs, it's part of breathing. And they will typically handle ascending aneurysms and dissections, okay, the aortic root replacements, and other conditions that involve the heart and upper chest, right? Vascular surgeons can do that too. They can do that too. Thoracic surgeons typically do not go outside of their realm and do surgery on other smaller arteries and veins. So vascular can do it all. Thoracic sticks to the thorax area of the chest. So your vascular surgeon is going to focus on the vascular systems, which are your arteries and your veins, including the aorta, and that would be anywhere in the body. And they typically manage your descending aortic and abdominal aortic diseases, often using minimally invasive open or open surgical techniques. So the type of surgeon that you're going to use really depends on where on your aorta you have your disease. And so in many cases, again, we cannot impress upon this on you, whatever the saying is, too much. Cannot impress this upon you enough. They're going to work together. So that's a great thing. So if you end up with a team, one of each, this is great. They're going to provide the most safest and effective care. So, but always talk to your care team so that they can explain to you which type of surgeon is going to be the best for you based upon your specific diagnosis. Because, right, this is all about acing your healthcare journey, and it's about understanding your options. It's about education, fulfilling one of those three important buckets, and that is your Aortic Disease Awareness Month clinicians post. All right, who do we have to say hi to? Anybody?
We've got a lively group today.
Like
Tom,
lively.
Talina, a person named Please and Thank You,
Okay, please.
Christina, and Velda, and Ryan has shown back up.
All
Velda
right.
says, "Hi, I escaped from the hospital, Yahoo." And
All
Talina
right.
asked the same question I asked, which is, Yahoo, Velda, I hope you're okay though. So I don't know.
Yes. Good. If you escaped because you were discharged, I'm extremely happy for you. If you escaped because you are a lunatic and just left on your own accord, then I'm not very happy for you. So I hope you're doing well. My thoughts are with you for sure. Hey, everybody, thanks for joining. All right, we are moving on to the next day, which was about genetics. It's just so funny that Ryan's here. Did he know this was happening? I don't know. But I do know that Ryan gave a great live interview. You can check that out by going on our website, clicking programs, and going down to live Q&A. You will see Ryan's video on there. You're going to see everything on there, but that's an easy way for you to connect to our AHTV YouTube videos. All right, we're going to talk about a lot of different things when it comes to Aortic 101 genetic diseases. So, all right, why do families need genetic screening? It's such a personal decision, but there's a good reason why, and that's because genetics, look, they all in all might sound complicated. I mean, they still do sound kind of complicated to me, and they sound not a little intimidating. They sound extremely intimidating to many of us. But it really can be a very powerful tool in protecting you and your family, and your loved ones. So the decision, while it's deeply personal, should always really be discussed with your family and healthcare team. Okay. So here's a quick snapshot when we were talking about genetics from the aortic dissection, the patient guide, pages 85 through 89. Here's just a quick overview. So some people have a genetic predisposition to aortic dissection, which that means it can run in families. Does it 100% of the time? Not as of today, September 15th, 2025, but it can, right? And if you've experienced a dissection before age 60, or you have signs that you might have a genetic syndrome, really finding out if there's this inherited cause, it's really especially important. You know, since COVID, my words have just gotten really jumbled. It's so weird. It's very weird. So sorry. Genetic screening can really help identify risks in you and in your relatives, potentially preventing future emergencies. These are the key things. And your primary care physician or your hospital team, they're the ones that might be able to refer you to a genetic counselor. And if there is no clinic nearby, which very well may be the case, you might need to have remote genetic counseling, and those services are available. And during your consultation, here's some of the things that you should come to expect, okay? And maybe even be a little prepared for, which would be super helpful so that your appointment doesn't take 3 hours. Just know your family history. You want to review the medical and family history. And I personally would say, until you know what they're looking for, leave everything. One time I was told, it, I think I asked, should I be telling you that periodontal disease runs in the family? And they're like, let me write it down. Like, nothing's off the table. If more than one person has it, I say bring that information up, because we are not the experts in deciding what information somebody needs to know to help make that puzzle more complete. You're going to discuss what you think might be some possible genetic causes. Your genetic counselor is going to discuss this information with you. And recommend any potential testing and or imaging. That could include CT scan or an MRI scan or an echocardiogram. This might include for you for sure and potential family members. So it's important, if you're considering testing, talk about the implications for things like life insurance and disability, because one of the things that we've realized over the years is that there's basically two different ways that you can do this genetic testing. You can do it clinical or you can do research. Now, if you want to do research, okay, some of the pros of research is it stays anonymous. So nobody's going to know, nobody's supposedly going to bring it up down the road and be like, oh, you had a pre-existing condition or you have an issue. It's anonymous, right? Number two, you're helping the society overall by contributing to a research study. There's no cost involved. That's a big one for people. There is no cost involved. Now, the downsides, no, downside, get the word right. The downside is that sometimes they only run their batches for a test in, let's say, 100. So if you're 27, that's your number 27 of submitting your saliva, you have to wait until they get to number 100. So you're waiting 73 more people before they're going to turn around and then run that batch. So if you're looking for immediate answers, you're not going to have immediate answers with research study. You might not get any answer with a research study, because I don't really think they're calling to say you have nothing. We found nothing. And that's okay, because again, the goal is to find people and to notify people and to monitor those family members and individuals that are at risk. John Ritter Research Program would be the organization I would tell you to look into if you were looking to do research route. Clinical, like GeneDx or Invitae, and I'm not talking 23andMe, I'm talking a true clinical test. I think there's like 38 aortopathies. These are the tests that they're testing for. You don't get to ask that. They already know what they're testing for. You usually will have your results, let's say 45 to 90 days, just to be worst case scenario. Okay, you will have your results regardless if something is found or not. Full explanations are on these reports as well, and you can discuss them immediately with your genetic counselor. And that sometimes has a cost associated with it, might not. And that information could or might not be used against you. I thought it sounds so horrible, but could be used in the future when you're looking to obtain long-term disability or long-term insurance. Right now, we're protected where pre-existing conditions don't matter. But when it comes to life insurance, all bets are off. If they find out that there's a genetic condition, you might be rated at a much higher rate if you are even rated at one that you can afford. So there's like a big con with the clinical. Again, that's why it's very personal. You want to have these conversations. But if you want to learn more information about this, you should download the Aortic Dissection, the patient guide, and check out those pages 85 to 89. And it's also in our second book as well. I mean, look, knowledge is power, and in this case, it can be life-saving. We have a whole series. If you go onto our website, you go under blog and push the Hourglass here and just look up Genetics 101. Everything that Ryan has created for us is all up there for you to review. Again, you can also review the video of his live event by going to the programs and then clicking live Q&A. And that is that post. I love September. I love September. Okay. Any questions, any comments or questions?
This new Selena account's actually Nathalie. So we have to remember that. I have to do my best to remember that.
Okay.
Chef Rob has joined the chat. He so
Hey,
graciously
Rob.
said, hit the like button, please. We like to hear that.
Yeah. Yeah.
Christina, she says, Velda, I'm glad you're released from the hospital with a new hip, I hope. Are you able to walk?
Mm-hmm.
And again, more questions. I have more questions, Velda.
Yep. All right. Let's move on. Our next one goes right into another live event that we had just prior to that, and that was with Dr. Kristen Watson. And this is all about the medications that are commonly prescribed for individuals that have aortic disease. So I'm not too sure if we were able to update her presentation because I do believe she incorporated some more Lasix and a couple other drugs, but it doesn't matter. It's an amazing presentation. And again, you can go up to programs, click on live Q&A, and you'll find it from Dr. Kristen Watson. But whether you're newly diagnosed or you're a long-term care patient, right, or you're even a caregiver, I mean, her talk, what she does, what she discusses, it's so important. I mean, she really does break down the most common prescriptions that are used to manage this disease, how they work to protect your heart and your aorta, right? And I think for some people, understanding the mechanics behind what they do really can make things a lot easier for people to have to take the medication, right? Um, it's also important to know the possible side effects you might feel, because without that, you might be thinking that the surgery has caused the fatigue or the surgery has caused the cloudiness in your brain, when actually it could be the overloading of medication. And there's so many different medications to take, so don't suffer in silence. Tell your physicians how you're feeling. Keep a log of that blood pressure, especially in the early days or whenever you change medications, because that's really the only way you're going to know, A, if it's working, and B, if the side effects could be from the meds. Okay. There's also information about talking with your doctor about your medication plan. So a lot of easy to understand information in here. I mean, she really goes over everything from beta blockers to ACE inhibitors to ARBs to all these things, angiotensin receptor blockers, the diuretics. I'm missing another classification, but they're all in there and they're all super duper exciting. So check that out when you get a chance, or go check out her live video. Okay, this takes us on to medical terminology. There's nothing that drives me crazy more than, why do I sound like I'm trying to talk about pasta? There's nothing that drives me crazy more than when someone is referring to an ascending aortic aneurysm and uses AAA as an acronym. Because AAA is abdominal aortic aneurysm. And so I get super confused. I'm like, what are we talking about? You're talking about ascending, but you're just using the letters for abdominal. I get it. People don't know, and they interchange this a lot. But that's why medical terminology is so important to understand. So Corrigan Minahan Heart Center had this great glossary on their website, which we kind of pulled into ours, giving them credit every minute we ever referred to it. It's a quick and easy guide. Like if you were unsure, aneurysm, pseudoaneurysm, dissection, endovascular echocardiogram, transesophageal echocardiogram. What do these words all mean? You'll find all that information inside of this glossary. It's very simple explanations, aortic specific terminology, and always available whenever you need it. So because when you understand the language, you can better understand your health. So there's a link right here that takes you right into the glossary. And our job is just to kind of make medical terminology clear and easy for everyone to understand. So if you ever were curious, check that out. All right, so much information. Okay. Let's now talk about diagnostic testing, because there's a lot of different types of diagnostic testing. So it's so interesting. So I'm going to talk about something after this. So the typical diagnostic testing, and I don't mean gold standard, I'm talking about anything that's going to help diagnose part of what you have. The tests that are done at any given period of time could include and should include a CT scan, okay? Unless you're super allergic, in which case they can do it without dye. Sometimes they can just pre-medicate you, right? But that is gold standard. And that's going to be detailed imaging of aneurysms and or dissections. MRI, next best choice, guys. MRI, cardiac or congenital, clear image of aortic tissue. Um, you have an echocardiogram. That's an ultrasound to assess the aortic structure. You might use an X-ray, basic view of aortic widening. Never really use that much in diagnostic. And an angiography. That's dye-injected imaging for blood flow and tears, okay? So let's understand the different tests that are typically performed. And each one has its unique strengths and the reasoning for using it. So if we talk about computer tomography or CT scan, what you're talking about is quick and highly detailed. And the reason they use this in the ER is because it takes 5 minutes. And you can always bump somebody easily if you're being rushed in for a potential life-threatening emergency. So that's one reason. And it gives the doctors a 3D view of the entire aorta. And it makes it one of the most common tools to dissect if you have an aneurysm or dissection. Now, magnetic resonance imaging or an MRI, there's no radiation exposure. No need for iodine-based dye, although you still have to take gadolinium dye, which most people do not have a reaction to. That's going to take about a half hour. The likelihood of bumping somebody isn't going to happen. So if somebody's in the MRI machine, and let's say the hospital has on average two, if they're both being used, you just can't sit there and wait a half hour, right? So a CT is quick every 5 minutes, but it's great for your follow-up imaging. So there's a lot of you out there that talk about, I don't know if I want to have another CT because I feel like I'm glowing in the dark and I'm being over-radiated. Talk to your physician about if they feel comfortable transitioning you to an MRI if that's something you wish to consider. It's all about asking questions, acing that healthcare journey with somebody. If you're a younger patient, if you need lifelong surveillance, it's a conversation worth happening, but it still does provide a very clear picture of blood flow and vessel structure. Transesophageal echocardiogram. So this is about as close as you're going to get to the heart. I mean, this is in ways better than a CT, but you can't give this to somebody in an emergency situation because an ultrasound is actually placed down your throat, down the esophagus to get really, really close to the aorta. I mean, just think about where the aorta is situated and you have esophagus coming down. Of course, you have your trachea coming down to go to the lungs, but it's just right there. It's just rubs up right next to your heart. And so you would need time to knock somebody out. There's no time for any of that. CT is still best because you boom, take them in. So the ultrasound is placed down your esophagus when you are knocked out with a little bit of propofol, and it gets a really close look at the aorta, and it produces these high quality images of the heart as well as the ascending aorta. And it is used in an emergency or during surgery, but not when I say emergency, an emergency surgery where they still have a little bit of time. It would be used before an MRI for sure. So it would be CT, TEE, MRI. Then there is the transthoracic echo, TTE or echocardiogram, right? So we just call them an echo. This is non-invasive, so it's not like a transesophageal. You're not going anywhere except rubbing some jelly with an ultrasound wand on top of your skin to be able to get a look at your heart and the part of the aorta. You cannot see all the aorta. It is the common first-line test to check valve function and parts of the ascending aorta. So together, these tools really help doctors diagnose, plan treatment, and monitor patients that are living with aortic disease. Again, knowledge is power. Understanding your testing options can really help you feel more confident and more informed during your care journey. And that's all part of acing your healthcare journey, right? Right. Okay. Anything I need to know about, Josh? Anything I need to know?
We're at 3:28, so I don't know how much more
Okay.
you have.
We're doing good.
Um,
We're whipping through.
Please and thank you has asked, can mitral valve prolapse, AFib, and A-flutter put pressure on the aorta? And I said, we have Dr. Udeman coming up at 4. You may want to hear from him on this question.
Good question for him. Hang out until 4 o'clock, probably around 4:20. He'll be more than happy to ask that question. If you're not going to be around and you want to ask it, throw it in like, and well,
And
we're just
Melissa
going to
has
write it
joined the
down.
chat.
Hey, Melissa. Mitral valve, what was that question again? Mitral valve, flutter.
Mitral valve prolapse, AFib,
Right.
and A-flutter.
So I'm not a doctor, but I'm going to guess because I like to find out if I'm right. My guess would be probably not because it's the mitral valve, which is inside the heart. The aortic valve is coming outside of the heart and it is going out. So it's not anything to do with blood that's flowing inside the heart. And flutters, you know, flutters that occur within the aortic valve are usually because that valve is regurgitating or it could be stenotic. So it's going to have some backflow going back into the chamber of the heart, which can cause an electrical disruption. But something from another valve, I mean, yes, you have backflow or you have something that's not going the right direction that's going to create flutter and can cause AFib. So what's going to ask the AFib specialist, Dr. Udelman, when he comes on? All right. Why aortic hope? We were talking about Hope Mail, you guys. We were talking about Hope Mail, and I still can't believe that it started with 4 of these red heart-shaped pillows that I knitted. I actually found one in my therapist's office that I needed for her after dissection when I went to visit her recently, and it's still hanging on her wall, which is so cute. And now we have like over 350 people getting Hope Mail packages, and it's packages that are sent out to you once a year as our way of saying, "Hey, we're cheering you on. You have our support. We're here for you." And thank you for your support as well. So here's like a small package that went out one year. It was a journal and a jar opener. We try to think of things that would be really helpful for you. So if there's anything that you're going to have on that to-do list, sign up for Hope Mail because it's free. So if you sign up today and your aortiversary was September 3rd, you're going to have to wait till next year. All of September's already been sent out, but not October. So you still have time to sign up now and you would get your Hope Mail some point in October. But again, if you have more than one surgical date, you have to pick one. And we will acknowledge you in that month, not on the day, but in that month of. And if you know that you have something coming up or you're on watch and wait and you've been diagnosed with that, please, tell us that as well. And there is a link for you to sign up for that too. So there you go. All right, we have some very exciting news. Now, maybe you're aware, you should be aware. If you're not aware, we have such a great sisterhood with our North American sisters out of Canada. Aortic Hope Canada was launched because there really wasn't a support group, a general support group that existed in Canada. They have a private page. They have a support group, and they now, very soon in the next day or two, will have configured their French speaking Aortic Hope Canadian private forum. It's being typed probably now as we speak. So that's all very exciting. So we'll have French and we have Canada, and it's wonderful and it's great. And now we have another international exciting collaboration to talk about, which did not even realize these are two completely different flags as they should be. But that's how off the beaten path I am when it comes to geography. We are extending our support on an international level, and I'm so excited about this because these conversations have been happening for a while now, but we're kind of collaborating with a very successful and established Facebook group called Aortic Aneurysm and Dissection Support New Zealand and Australia. So our friends down under, mate, they are now going to be able to be encouraged to have full access to our AHTV library and contribute, which is what's really cool. We really want to help them enhance their capacity to provide support and share survivor stories and engage in live events and do that with their clinicians, providing information about what goes on in their countries. And we're here to help them do that. So we're starting this month with sharing all of our medical posts and some other support posts with their country. We're starting to see an uptick again in our followers, which is great. And I'm hopefully we'll be able to get some of their community members to participate in our Survivor Series as well. It's just another way that we're creating awareness and saving lives, one beat at a time. And that's what we do. So yeah, look at that. And as we talked about before, we're doing it ASAP because we know awareness saves aortas, period. So very exciting. So I guess we're like basically now beyond North America. We are officially international. And so look for support group meeting to hopefully be ready to go by January for our friends in New Zealand and Australia. Very exciting. So exciting. Yay. All right. Okay. This is taking us to a senior healthcare journey during the month of September. It really should happen all the time. I got to implement this firsthand today. Let's talk about this before I get into that. All right. So this was created not to become a power struggle, but really to be a true power balance. This was created last year, presented in Scotland, and so incredibly well received. When it comes to our health, many of us tend to fall into that old pattern regarding our relationships with our physicians. And that's, we say, this is what's wrong with us. And they say, this is what you need to do. And we say, oh, okay, we're going to do it. And we keep our thoughts and our opinions to ourselves because they're doctors and we don't want to annoy them. And we don't want them to think that we're hypochondriacs and that we're. So when we don't feel well, we do the same thing over and over again. Here's what's wrong. You tell me what to do. I say, yes, please, thank you. And we just keep doing that. And yet we're not sharing if we're uncomfortable or we don't like the idea because they're the doctor. They know best, right? But you know what? When you've been diagnosed with aortic disease, that cycle really can become very overwhelming very fast. And sometimes it could actually be very dangerous. So you really need to learn how to ace your healthcare journey. And look, it's so simple. It includes advocating, communicating, and educating. Your healthcare journey is more than just appointments and test results. It's the entire experience from finding the right provider to even paying the bill. It's everything in between. And it's works really, really well. It's a great partnership. It's just not a power struggle. Okay, so this is how you do it. And it's really, really simple. You advocate, you take control for yourself, you keep records, you bring a supporter, you go to appointments with family members, you come prepared and you take notes. You're going to tell them how you're feeling. You're going to put your foot down on certain things if you need to and say, well, this is what I need. The goal of advocating is to communicate what you need to be the best compliant patient possible so that you can have the highest degree of success, right? Then you have to communicate. And so what's the best way to communicate with your team and your physician? Is it going to be the portal? Is it going to be email? Is it going to be like me and text message them, right? You have to figure out the best way that you could communicate, what makes you feel comfortable. You have to be able to ask questions. You have to find a way to be able to do that. And you have to be able to speak up about symptoms you're feeling, treatments, and procedures that are coming your way. And the last thing is to educate. So you have to share what's going on with you physically and emotionally. If you do not tell them, they are not going to read your mind. So you have to know your family medical history. You want to help your clinicians see the entire full picture. Educating them allows them to educate others about you so that your entire aorta care team has they're just fully armed. You have the A team, right? The strongest healthcare journey is a two-way street. You bring your lived experience and they bring their expertise. And together you ace it. So it's no secret at this point, I think, that I am going to 99.9% have to have surgery, have my valve replaced. I've been keeping a video diary, AKA making a little documentary about this. And today was my go in to see the surgeon, meet the brand new surgeon. And so I brought Terry from Aortic with me because she's down the street. She had her notepad and she had her pen. And for a while I was waiting, we sang songs and I entertained everybody on camera. And, you do what you need to do to get the nerves out. But boy, it's been a really bad couple of weeks. Last week was the worst for me. I digress. So in comes the doctor. My initial reaction is, nervousness because he holds all the answers. And now I have to bring my A game and listen and actively share and not feel like I'm there's no way to overshare in your care. I'm going to write that down. No way to overshare in your care. I swear these things just pop out of my brain. There's no way to overshare in your care. So when we were talking and he was reviewing with me, drawing this great picture of my aorta with the graft and what might be going on with my valve and what he would do and all this stuff. Um, you know, Part of what I had to do was to advocate for myself and make sure he knew my background, make sure he was fully aware that I have a gene, a cardiomyopathy gene. I wanted to ask questions about that. As stupid as they sounded, it's questions simply like, okay, well, if it isn't my valve and my heart function is decreasing, am I just going to walk around one day and just drop dead like my father did because I have this gene? And he's like, no, you're not. And I'm like, okay, you stupid question. So somebody might make them oddly giggle, but I had to know. I have to know that I'm going to be okay. The other thing I had to do was make them fully aware that I do have PTSD, residual PTSD, and I am triggered by health related issues and I do not like pain. And that the moment I check into this hospital for my day of surgery, as soon as that IV is put in, knock me out with Versed. I don't need to talk to anybody. I've already said goodbye to my family. Just make me comfortable until you have to roll me in, because the longer I'm awake, the more I'm actually internally suffering. They said, well, let me make a note. And they made a note. And literally, we talked about everything. I asked for explanations about things. We both agreed that it makes sense that before I just jump in for surgery, we want to know everything that's going on with me. So I'm going to have a CT angiogram, which means I have to be put inpatient because I'm highly allergic to the dye. So this way they can fully medicate me, do the CT angiography, make sure all my blood vessels are good and I don't have anything compromised from any vascular disease. And then the next day I'm going to have a transesophageal echocardiogram because it gets you the closest to the heart possible. This way he gets the most detailed, closest image of what's going on so there is little to no surprises. Who wouldn't want that, right? So that's what's going to happen. I have to get those scheduled. We talked about that. I said, well, how much pain am I going to be in compared to the first one? All I can compare my surgery to is a dissection. He said, you'll be in a lot less pain. And, it was just a beautiful experience because I viewed him almost as a peer that just happens to know his medical stuff. But I know the community. And so he let me videotape this whole interaction so that I could educate all of you on what a senior healthcare looks like in action. So we'll get to see that stuff soon. I'm very excited. Not excited about surgery. We're not even going to go there, but excited that I got to do this and I can share it with you. All right, because time is of the essence before I jump into my next event. Yes, we have a lot of stuff sitting up here in our events because I like to leave September up so I can track everything that we're doing. And I like to recall everything and review it all with you. But here we are. We're down here Monday the 15th. We have a 4 o'clock right now at Dr. Ben Udelman, cardiothoracic surgeon out of Maimonides Medical Center. He is a hoot and a half. We're going to be discussing primarily aortic dissection. So we're going to talk about the aorta. We're going to talk about the type A versus type B, which is DeBakey, versus Stanford type 1, 2, or 3, all the same thing, just different ways of classifying. What the main differences are, the significant differences, how to diagnose, how to treat, how to monitor other family members. We're going to talk about all of it. Do not worry if you have a question that's not related to that, like our question from our please and thank you person earlier asking about mitral valve. Please bring your question to the conversation. Just remember, this is just for informational purposes. Take this information to your own physician and have that discussion because they are the ones that know your medical care. And then later tonight at 7 p.m., we have an interview with Dr. Beaver, brand new doctor from us. He is out of Shands Hospital out of Gainesville, University of Florida. We are talking all about aortic valves. We're going to talk about bicuspid valves, and which is congenital. You're born with that. We're going to talk about aortic stenosis, aortic regurgitation, monitoring, treatment plans, the whole 9 yards, show and tell. And then he's going to talk about a new paper that was just published with himself and Dr. Bavaria and a couple other names you've heard in the community for working with Edwards Life Science on a valve and what the long-term results are showing, which is very promising as far as longevity with this valve. I'm going to let him share all of that information with you. And then we have later tonight our caregiver meeting, caregiver support group meeting on Tuesday. I thought that time got changed. I could be wrong. I could be just totally seeing things, but we're going to double check that. I don't want to take up our time. On Tuesday, we have no, on Tuesday, why does it say Tuesday? It's actually, yeah. On Tuesday, we have a live event with John Martin at 7 p.m. And on Wednesday, we have a live with Robin Peacock. So that has been switched. But so tomorrow night, we have a live event with Dr. John Martin talking all about abdominal aortic aneurysms. And on Wednesday, we're meeting with Robin Peacock from Heart Valve Voice. We're going to talk about their theme this year, which is happening this week, women and heart valve disease and how differently it presents. So for the ladies out there, you might want to take a listen into that. And then we have a live Q&A coming up with Lawrence Hope, although I think that is being rescheduled. I will keep everybody posted. Hey, final thing before I get into everything else, because I can get into that next week. We have illuminations. We are illuminating the United States on Thursday, Friday, and Saturday into Sunday now. We have numerous locations across the United States that we are lighting up in honor of Aortic Disease Awareness Month and for Aortic Hope. Things are going to be turned red all over the place. Check out those posts. Check out that locations, take a picture, take some video, and just send it over to me or send it over to info@aortichope.org. And we can't wait to see everything being lit up this month. So this is new for us. We're super excited. And that is it because I know I need to go. I'm wrapping it up. Thank you, everybody. Thanks to everybody who joined and listened and chatted amongst yourselves. Sorry I didn't get to hear everything you have to say. It's so important to me, so I'll hear it next week. I appreciate you tuning in. It means the world to me. Don't forget, click like, click subscribe, click that little bell, and I will see you guys. I'm going to see you in 10 minutes. I'm going to see you in 10 minutes, or I'll see you next week for Week in Review. Take care. Bye-bye.